Medurstand. Understanding medicine.
I'm Professor Aziz-ur-Rehman, and today we're going to take up this condition called pneumonia. And it is going to be a slightly lengthy topic, so I have divided it into two. And in today's lecture, we will cover etiology, clinical features, and diagnosis. Now, some introductory comments. It's a fairly common condition, but not very common. Luckily, respiratory tract infections are mostly simple pharyngitis or rhinitis or tracheitis or just simple flu symptoms. Very few patients out of those who have respiratory tract infection will actually have pneumonia. It's a potentially serious infection, no matter what your age and what is your general health like, but it is potentially serious. In some situations, it may be very serious, but in others, it is potentially serious and treatable condition. What is the definition? Pneumonia is an infection of the pulmonary parenchyma characterized by acute inflammation. Now, this is a very vague definition. I'm sure nobody can actually diagnose pneumonia just by knowing this definition. So, but few points I like to emphasize. It is the infection of pulmonary parenchyma, not just the trachea, not just the airways. It is the entire lung parenchyma. That means alveolar structure, the air spaces and the small airways, they're all affected. And number two, it is characterized by acute inflammation, acute infection. In fact, whenever a pathologist talks about acute infections, usually they give example of pneumonia. It's very severe acute inflammatory reaction characterized by pouring in of neutrophils, and then there are different phases it goes through, and then usually there is recovery. And all acute inflammation, acute infections are characterized by certain clinical features and certain laboratory abnormalities, which we're going to cover in this lecture. Now, salient features. Number one, it is a group of disorder. Pneumonia is not one condition, it is actually pneumonias. There are various types. You can classify pneumonias based on etiology. You can classify pneumonias based on their setting, and you can classify pneumonias based on other factors, the predisposing factors. So I'll give you some classification also. Then a classification can be based on morphological appearances on X-ray. That means how does this pneumonia look on X-ray, and etiology, what is the exact organism, and the clinical classification is also there. Then microbial diagnosis is very crucial. Now, since it is a potentially serious infection, in many infections we treat patients empirically, but this is a situation where microbiological diagnosis is very crucial. Now, it is extremely important if we can find out which particular organism is causing pneumonia in particular individual, because the choice of antibiotic is different. Now, I must confess that is not possible in all the cases, especially in our settings. So we try to make an empirical diagnosis, but we do try to find the actual organism so that we can give the proper treatment. So it is extremely important if we can find the actual organism and also the culture and sensitivity pattern of that particular organism. Initial therapy is usually empirical, because patients with pneumonia, they have this dry cough and high fever as a presenting symptoms. Now, the classical sample for isolation of bacteria is sputum, and patients usually do not expectorate phlegm in the initial few days. So that time, based on the clinical settings and the radiological appearance, we try to make a diagnosis and we start empirical therapy. At that stage, blood culture is also possible. But since blood culture also takes time, Any sample, if you send for blood culture, it is going to take several days. So we suspect something, we draw appropriate samples, but the diagnosis is then the choice of antibiotic. At least starting antibiotic is empirical, and once we receive the culture reports, and also by the time we also know how well patient is responding to the antibiotic which we have started, then we make the changes if necessary. Pathogenesis. Now there are three mechanisms organism can reach our lower respiratory tract. Organism need to reach the lower respiratory tract, the lung parenchyma, only then there would be pneumonia. First is aspiration. Now aspiration means that our pharyngeal secretions, our nasopharynx has got normal commensals, and streptococcus is a normal commensal of respiratory tract, and that happens to be the commonest organism responsible for pneumonia also. So these organisms are present in our upper airways. So if we aspirate them, normally we have a very efficient mechanism of swallowing our pharyngeal secretions and destroying them in the stomach. But in somebody who is immunocompromised, or is not very well, or is bedridden, or sometimes without any obvious reason, because of temperature change our ciliary function is down, or because of smoking the ciliary function is down, so pharyngeal secretions may be aspirated. Now when we use this word aspiration, we usually refer to somebody who is admitted or is a patient of stroke and he aspirates his vomitus or his stomach secretion. But actually the community acquired pneumonias, if you go into the detail, most community acquired pneumonias are also technically aspiration pneumonias because they aspirate their pharyngeal secretion. Second is inhalation. You could inhale some organism directly from the environment. This would be particularly true in occupational pneumonias. So there is a germ in the environment, and during normal breathing one can inhale them into the lungs. And third is hematogenous. That means there is some infection somewhere in the body, pelvic inflammatory disease, urinary tract infection, osteomyelitis, endocarditis, any infection anywhere in the body, and there is bacteremia, and these bacteria may settle in the lower respiratory tract, and that may result into pneumonia. So these organisms, they have to face multiple levels of resistance. There are antibodies on our mucosal surfaces, then there are macrophages in our mucosa, then we have antibodies in the blood and other mechanisms. So these organisms, they can reach lower respiratory tract but do not necessarily cause infection, do not necessarily cause pneumonia because of this resistant mechanism. But some bacteria would evade this mechanism and will actually reach our lower respiratory tract. So that will result in acute inflammation. Now, lung is a unique structure. It has got lots of free space, alveolar space. So there is an opportunity that this inflammatory exudate fills this air spaces. So that is actually technically pneumonia, when our alveolar air space is filled with exudate and the air is replaced with this exudate. The lung becomes more or less solid. So that is why we call it consolidation. So lungs become solid, and during that phase they cannot ventilate. They continue to have perfusion, but they do not ventilate. So there is a kind of right to left shunt. So that would also cause some laboratory abnormalities. So it's acute inflammation. Acute inflammation will pass through various stages, and unless patient ends up in complication, patient will recover completely. So this would result in consolidation. Consolidation is a phenomenon where a sponge-like lung structure is converted into a more or less solid liver-like structure. So we actually call it hepatization. So that is consolidation. And in majority of the patient, those who are immunocompetent and those who are given proper antibiotic, they would have a resolution. That means lung will regain its function. It may take several weeks, maybe up to 12 weeks, and this regain of function may not be 100% complete, but mostly there is a resolution. But some patient may end up in complication. That means this consolidation may transform into lung abscess or empyema, or patient may have endotoxic shock, and patient may develop hypovolemia and other possibilities. Luckily, in majority, we expect a complete resolution. Now, classification, you can classify pneumonia based on various factors. Let's first take etiological diagnosis. This is perhaps best because the treatment is focused on etiology. If we know for sure which particular organism is causing infection, I think we are in the best position to give right antibiotic, and the chances of recovery would also be best. First of all, bacterial infection. The common infection is caused by streptococcal, especially because this is our normal commensal. And then also mycoplasma. Most community acquired pneumonias, I will talk about this term also later. So streptococcal or mycoplasma pneumonia is the commonest cause of a community acquired pneumonia. Streptococcal of the two is commoner. How does that help? Because we know which antibiotic works best for streptococci. Although recently streptococci have developed resistance, we need to have some information which antibiotic is effective these days in our community. Then tuberculosis. Tuberculosis can also cause pneumonia, although tuberculosis typically would cause a fibrotic cavitating lesion that is different than pneumonia, but technically it is also responsible for causing pneumonia, especially in immunocompromised people. Then viral pneumonias. The virus can cause pneumonia in two ways. Number one, virus itself can cause pneumonia. That is relatively more serious. But there is a possibility of bacterial infection following a viral infection. So in that case, it would be a bacterial pneumonia, only precipitated by viral infection. Fungal pneumonias, very, very rare, only seen in people with compromised immunity. People who have HIV infection, people who are on immunosuppressant therapy after organ transplant, or those kind of people, not normal people. Then parasitic pneumonias are also common, but they are very rare. So I think when we talk about pneumonia, unless specified, we actually talk about this streptococcal or mycoplasma pneumonia. Then we can also classify pneumonias based on morphological appearance on X-ray. X-ray is the main investigation in pneumonia. So we try to get an X-ray. In fact, X-rays are taken serially. Based on what we see on X-ray, we can classify pneumonia into either typical, and typical means lobar. So lobar pneumonia means because of the resistance caused by septa, pneumonia typically involves one lobe. Of course, at the time of presentation, it may be just part of lobe, and at the time of presentation, X-ray may look just normal. But in a well-developed pneumonia, it will be one whole lobe. It may be upper lobe, middle lobe, or lower lobe. So depending upon that, we classify it as middle lobe pneumonia or upper lobe pneumonia. So this would be typical. If it is caused by streptococci and patient has got typical involvement of a lobe or part of lobe, we call it typical pneumonia. Then we have atypical bronchopneumonia. Now, atypical, of course, means that the radiological appearance is not typical of lobar. So there is a more patchy infiltrates, more likely to be bilateral infiltrates, and there may be more systemic manifestation. And this atypical is more likely to be mycoplasma, chlamydia, or some other atypical organism. So based on radiological appearance, we can classify pneumonias into typical and atypical. Then the setting in which pneumonia develops. This is extremely important. This actually gives us the clue toward the possible etiology. So number one, community acquired pneumonia. If somebody comes to the hospital with pneumonia, that will be classified as community acquired pneumonia. So why we are interested in this classification? Because we know that certain organisms are prevalent in the community, and if somebody has a community acquired pneumonia, he or she is likely to have either strep pneumonia or Haemophilus influenzae or chlamydia or maybe Moraxella catarrhalis. So these are the organisms which are usually responsible for community acquired pneumonias, and these organisms usually respond to antibiotic better, and these individuals may be treated as an outpatient. Hospital acquired pneumonia, any infection which develops in the hospital is very difficult to treat because germs in the hospital are typically resistant to antibiotic. Now this implies that patient was admitted to the hospital for some other reason, like for fracture of bone or for stroke or for some other reason after some time. So by definition, it is required that infection was not present at the time of admission. So sometime later, so maybe 48 hours later, patient develops febrile illness and then develops pneumonia. So that means the organism responsible for this infection are those which live in the hospital, and they have inherent antibiotic resistance, and these organisms are usually gram-negative pseudomonas, those organisms. So then there is a specific type of pneumonia which develops in people who are on ventilator. So ventilator associated pneumonia, this is the most difficult pneumonia to treat because these organisms are typically very resistant, and when you intubate a patient, you actually circumvent many of the defense mechanism. The tube is passed right into the airways. So because you bypass many of the immune mechanisms, so infection is typically very severe, and antibiotics are very special which are used in ventilator associated pneumonia. In these two, antibiotics are usually high dose specific antibiotics usually intravenously for maybe 2 weeks. Then pneumonia seen in people with HIV and AIDS, Pneumocystis carnii, although they have changed its name, but that is still very well known name. So that kind of pneumonia in people with HIV and AIDS infection, and then those who are neutropenic, patients who are immunosuppressive therapy, they may have specific type of pneumonia. So this is the pneumonia based on setting. What is the importance? Because if you figure out the setting, you can actually have a better idea which particular organism may be responsible, and you can choose antibiotic better. Now this is some of the examples, some pneumonias which occur in some specific occupations. Because of the occupation, we can make a guess. For example, bird handling, the patient's occupation is bird handling, that patient may develop psittacosis or bird flu. Of course, that individual can also develop simple community acquired pneumonia. Those who work with air conditioners, they may develop legionellosis. Those who live in dormitories or in camps and hostels, Mycoplasma pneumoniae is common. HIV and AIDS, Pneumocystis carnii. Rodent exposure, HPS or plague. So these are relatively rare types of pneumonias, right? So, but if somebody has a specific occupation, you can actually guess the type of pneumonia in those situations. But remember, these individuals, they can have simple community acquired pneumonia also. Now, this slide I'm going to explain some of the features, the clinical features. Pneumonia passes through various pathological stages and that translates into various clinical findings. So that I'm going to explain to you. So you should expect different physical finding on different stages. At the time of presentation, patient has this edema. Edema means infiltration of neutrophils and exudates into alveoli and interstitium of the lung. So that is edema. And at this stage, you can expect crepitations. So there would be normal air entry, normal breath sound, but you will hear crepitation, which will be heard on a specific part of the lung, depending upon the area affected. Right middle lobe, left base, or whatever area is affected. You need to be very meticulous in your examination. You must examine chest from all sides and very carefully with exposed chest. So I think if you can do that in the initial part, you can expect some crepitation, usually fine crepitation in the affected part. Now then, once this becomes more solid, the fluid is absorbed, then all interstitial and alveoli are filled with semi-solid structure, and that is called red hepatization. Red hepatization because there's a lot of blood and blood has RBCs. At red hepatization, this part of the lung is not ventilating. It is being perfused but not ventilating, and the breath sound produced by the air entry into the bronchi, that is transmitted into the stethoscope, and we have typical bronchial breath sounds. So we will have bronchial breath sound, and along with that you may also have increased vocal resonance, vocal fermitus, and there may be also called agophony. So these kind of abnormalities you may be able to hear on that affected part. Then there is a separate lecture when we say these are bronchial breath sounds. Let me briefly explain. If you have breath sounds which are hollow in character and has got a very clear loud sound, and there is no gap, there is a gap between inspiration and expiration, and that is a kind of breath sounds we call bronchial. Then red hepatization is converted to gray hepatization. That means RBCs are absorbed by macrophages or expectorated, and then you have liver-like structure, but it is gray in color, and then you actually, this is the same stage. I think you would have bronchial breath sound and also increased vocal fermitus and vocal resonance. And lastly, once there is a resolution, then again similar situation like initial one, you would have again free fluid in the interstitium and alveoli, then again crepitations will develop. Now, one person may have different physical findings because the entire affected lung may be passing through various stages. So at one particular point you may be able to hear crepitation, and another part there may be bronchial breath sounds. So this is how we diagnose. I think for an experienced physician, diagnosis of pneumonia should be easy. At least a physician should be able to suspect that this is the part which is affected in pneumonia. Then more details can be found on X-ray. Symptoms, there may be cough. Initially, cough is dry, hacking. Later on, it becomes productive. And the sputum is, once patients start expectorating, sputum is typically rusty. That means it is just like rust, because a patient is expectorating RBCs which are now altered. There may be fever. Fever is typically high grade and is usually continuous. So that kind of fever. And there may be chest pain, the affected part, wherever there is pneumonia, that part there may be pain, and this pain is pleuritic in nature. By that we mean that pain increases on breathing, on coughing, on sneezing, on laughing, or in changing posture. Because of the inflammation of overlying pleura, there is, whenever we do these things, there is the both layers of pleura, they rub against each other, and that causes pain. So pain may be severe, and it is usually pleuritic in nature. Then once expectoration starts, it is rusty sputum, I have already explained. So these are the symptoms, and then let's talk about signs. High temperature, and there is toxicity, that if you measure temperature, you are likely to see like temperature 102, 103. Not that patient will always have high temperature. There are people who do not have high temperature. In fact, the high temperature indicates good immune response. Those people who have pneumonia but fail to generate a febrile response, they may have relatively poor prognosis. Toxicity, that means once you just have a look on the patient, patient looks very sick. So that is the clinical feature. Then fine crepitation on the affected part, dull percussion note, because that part is not ventilating. It is the air which gives rise to typical resonant tone on percussion. So if that part is not ventilating, is converted into a more or less solid structure, there will be dull percussion note and pleural rub, the sound produced by the rub. It can be heard. It has got very classical superficial leathery character, and when you are auscultating, you ask the patient to hold the breath and the rub will disappear, and when you press it a little harder, the sound will become a little louder. It may be sometimes difficult to differentiate pleural rub from crepitation, but I think an expert would easily do it. Then bronchial breath sound may be a sign. So these are the signs. I think again, if somebody has a fully developed pneumonia, you can expect one or more of these physical findings. Then reduced air entry, particularly if there is associated effusion. Some patients with pneumonia may develop what we call parapneumonic effusion. So if there is effusion, that would actually increase the distance between the chest wall and the ventilating lung, and the breath sound will be reduced in intensity. This is the pattern of fever. A patient with simple uncomplicated pneumonia would have just one episode of rigors and chills when pneumonia develops, when there is initial bacteremia, but then typically there is continuous temperature lasting for 7 to 10 days depending upon the severity, and then there is defervescence. This is the typical pattern. But somebody who develops complication in the form of lung abscess or empyema or some other kind of complication like endocarditis, that patient is more likely to have multiple rigors and chills and ultimately slow resolution with the use of antibiotic. Investigation: initially, if patient is having dry cough, then the only sample we can expect to give us the etiological diagnosis is the blood culture. So blood can be drawn and sent to the laboratory. Make sure patient is not started on antibiotic before you send blood culture. So blood culture is the very good, but sorry, blood simple examination, because it is acute inflammation, we expect some finding, and I'm going to show you in the next slide what are those findings. So simple blood complete examination, or we call it CBC these days, or blood culture and sensitivity. X-ray test is extremely important. I think all patients with suspected pneumonia, you need to have an X-ray, usually PA, but you could also have lateral film to better localize the consolidation. Then sputum test. As I said, initially patient may not be expectorating. Only third, fourth day patients start expectorating. Sometimes patient comes late, so if patient is having productive cough, you must avail this opportunity to collect the sample, sputum sample, and send it for gram staining. Gram staining will tell you what type of organism, gram positive or gram negative organism are present. Then Zn staining will tell you if this is mycobacterium, and culture sensitivity will tell you the exact antibiotic to which patient would respond. This is the example of blood complete examination. You expect prompt leukocytosis. Now you know normal TLC range is 4 to 11. Now this patient is likely to have something like 15, 18, 20 or even more. Some people may also have what is called leukemoid reaction. The TLC could go beyond 30. Some people, they may not develop leukocytic response because of immunocompromised status, but majority would have prompt leukocytosis, and there is predominance of polymorphs, and there is shift to left. That means more younger cells with single cells which are called band cells. They are in majority, and some might also have toxic granulation. I can't actually discuss this more in detail because that will increase the time of this lecture, but there is a typical picture which we see in acute infection, and you will see that picture in pneumonia. Then if you are able to collect sample and do staining, and sputum will look purulent, and that means if you see it, it will be yellow or green or maybe blood stain, and if you see it under a microscope, you will see presence of pus cells and neutrophils, and if you see these bacteria present within the neutrophils, and that is very diagnostic, intra and extracellular organism, because it is normal to isolate organism or to stain organism from the sputum. But if they are present within the neutrophil, like in this case, you can see this is the neutrophil, and there are some, I think these are streptococci. From their looks, we can tell that these are streptococci. So these are streptococci ingested by the neutrophil, or these are bacilli, maybe influenzae. These are also present. So based on these, we can have fairly good idea if it is streptococcal infection or mycoplasma or other infection. Mycoplasma doesn't easily grow, so I think it doesn't also easily cultures. Mostly it is a presumptive diagnosis. So arterial blood gases may not be necessary in all patients, but those patients who are sick, those patients who are in impending shock, those patients who are hypoxemic, they should be hospitalized, and we need to do their blood gases. Or we can at least have their blood gases estimation on pulse oximetry. I think that should be done on all patients, but proper arterial blood gases should also be done. We expect hypoxemia for two reasons. One simple explanation is a part of lung is not functioning. But you know, if we remove one lobe, there is no hypoxemia. The actual explanation of hypoxemia in patient with pneumonia is that the part which is involved in the process of pneumonia, that is not ventilating, but that is being perfused. So there is ventilation perfusion inequality. So it's a kind of a temporary right to left shunt. So there is a blood which passes through the lung without getting oxygenated. So these guys, they develop hypoxemia. And they may also develop a respiratory alkalosis because they hyperventilate. And you know, carbon dioxide is much more diffusible than oxygen due to hyperventilation. They may breathe out a lot of carbon dioxide and may develop a respiratory alkalosis. Then the best investigation is X-ray. And let me tell you that I have a separate lecture series in the same channel called Radiology for Internists. I have discussed these morphological abnormalities in much more detail. If you are interested, you can refer to those videos in Radiology. The playlist name is Radiology for Internists. But here briefly you can see this is the consolidated part. This part is consolidated. It's not pleural effusion because this part is clear. And this is another person, this is also consolidated. So these are two right lower lobe pneumonias. These consolidation, these opacities are more or less uniform, and they are correspond to a particular lobe, but they do not obliterate these angles. And they also really do not increase the lung volume because they just replace this consolidation, just replace the alveolar air with exudate. Usually there is no increase in the volume, so there is no displacement of midline structures in majority, but of course in some cases there may be atelectasis, in other there may be associated pleural effusion. In that case there may be shift of midline structures. Further details you can see in my other videos. This is the middle lobe pneumonia here because of a location, and this is upper lobe pneumonia. This is transverse fissure. This is very sharp border. This is called the transverse fissure, and the consolidation is very uniform and is affected the entire upper lobe. So this is upper lobe pneumonia. This is middle lobe pneumonia. And this is again lower lobe pneumonia. In the left side you can see this is the opacity, and not exactly corresponding to one whole lobe, but this is the opacity. Now there is something called Silhouette sign. Silhouette sign means that if the affected part of the lung is in physical contact with the heart, then you will not be able to appreciate this border. In this case, you can see this opacity, you can see this opacity of the heart also, but you can also appreciate the left cardiac border very clearly because this opacity is not in physical contact with the heart as shown here, because this is affecting the posterior part of the lung. So this is how we can tell on X-ray which particular part of the chest is affected. It's called Silhouette sign. And there may be some pleural effusion because this angle is obliterated. I believe small amount of pleural effusion is present in majority with pneumonia, but when we say pneumonia with effusion, we actually mean we only label this condition when there is significant pleural effusion. So this is actually, I think, the case. You have bilateral opacities. And this may be a case of mycoplasma pneumonia. People with mycoplasma pneumonia, they have more likely bilateral involvement, and this patient has got obliteration of costophrenic angle and cardiophrenic angle, and you have this, no, you can't see the diaphragm, you can't see cardiac border. This indicates that in addition to bilateral consolidation, there is perhaps pleural effusion also bilateral. So this is another presentation. Thank you very much. That concludes only the first part of pneumonia, and we have covered etiology, classification, and the diagnosis based on clinical features and laboratory tests and radiology. In my next lecture, we will discuss the treatment.